Hello, good afternoon. It is Tuesday, April 8th, and we have worked furiously the past week or so to get out some excellent Senate bills. And we are moving on to S-126, which is a bill that we intend to spend a lot of time on. And we're really honored to have the reporter of the bill and the chair of Health and Welfare with us to introduce this bill to us.
Well, thank you. Senator Ginny Lyons for the record. I haven't looked at the bill since we passed it out of the Senate, so it's going to be a refresher course for me as well. And I don't know, I do know that you've taken testimony from folks, and we had a couple of meetings together where we brought in some experts. And I know you've also been talking with Elliot Fisher as well as others on this. So I started working on, obviously, we've all been working on healthcare reform for a long time, and we get it. We understand. We've worked together on financial sustainability of our hospitals. We know that some of our hospitals have been in the red for a while. We've tried to put financial sustainability plans in place. The Green Mountain Care Board has worked on those plans because we can't lose what we have in our state. In fact, we want to improve it. So I started thinking about, as a result of the Act 167 work that we did in 2022, began to think about where are we in our healthcare world. And last May or June, started to thinking about the crisis that we're actually in, the cost crisis that people continue to be concerned about, and realize that it isn't a simple fix. You all know that, and I know that. It's more complicated than that, as we say in our committee. It's complex and it's more complicated. So as the Green Mountain Care Board contractor went about their work with the Oliver Wyman report coming out, and that was an eye opener for, I think, everyone. It was scary. People were afraid of losing local hospitals, but in the same way, there were rational concerns about high cost care and wanting to lower cost of care. And at the same time, we have been putting money into survival for hospitals and other community healthcare facilities. We can't afford to keep doing that. So it's a matter of where is the money and how can we redistribute it, perhaps? How can we make it balanced and fair at the same time that we're transforming access to care, filling the gaps for those for care services across the state? So I started building a framework for the bill after through the summer and through the fall, knowing that there were huge concerns across the state about what the report had said, and it was frightening to everyone. We were also hearing that our largest hospital had some of the highest costs in the country. We know that when you look at the per capita cost at UVM is just very high. And we compare it with our neighboring states, like of Maine, New Hampshire, others, it's percentage is high. So say, is it $800 to $400? Is it $1,500 to $600, depending on how you evaluate? And then we also are very concerned, all of us in this room, concerned about how we expand and improve our access to primary care, which is so significant for prevention and can also ultimately lower healthcare costs. Boom. So it's all those things in our heads. One of the things that I had talked with, I don't know, some of you may know Craig Jones, who used to work for the Blueprint in the state of Vermont, and has done a great deal of work in that area. And I talked with him about what, last April, I guess, about what can we do? He said, well, what do you want to do? And I said, well, I really would like to see some unified electronic medical records. That's an important step for us to take. And he said, yes, that's really important. So that was reinforcing. So that is part of the bill that you have before you. And then thinking about, well, we do need to look at hospital financial sustainability. That's key. We need to look at what we need across the state. And obviously, transformation process that AHS is going through right now is all a part of that. All of these things just fell on top of us, didn't they? When the Oliver Wyman report came out, it said to me, it just reaffirmed all the things that I knew that we needed to do. There are things in there that we need to do. You know that as well as I do. It wasn't lightning, it wasn't a lightning strike. It wasn't new information. But I think it helped to reinforce what we know we need to do. So building the framework for the bill, I focused on the three areas: hospital budgeting and financial sustainability. And that can lead to the development of increased access to primary care. That's in the bill. Two is the development of a state healthcare action plan, which we'll talk about a little bit, that responds to changing community needs. That's a very important part, the second part of the bill. And then the third part of the bill is the medical records unified data space, as some call it, sharing to make healthcare clinical data more accessible to providers and patients altogether. So as you go through the bill, you'll see all of these things. We've tried to give attention to some pretty basic decisions when hospital budgets go through the Green Mountain Care Board process. We've tried to enhance the Green Mountain Care Board responsibilities and allow for them to do things that they haven't been able to do in the past. And when budget decisions are made that would result in a loss of services, we want to ensure that those services are not indeed lost unless there's some accessibility through the state or locally for folks. We would like to ensure that whenever budget decisions are made that reduce costs in hospitals, that translates to what comes out of our pockets when we pay for our insurance premiums or healthcare. So those little things for me are exceedingly important and difficult to do. So it's a huge burden on the Green Mountain Care Board to come through with some of these recommendations. It's also a burden on our health insurance company, in particular Blue Cross and Blue Shield, who are currently underwater, and how they can work together with providers and patients and facilities to ensure that all of this coalesces and builds a new way of paying for healthcare and helping folks access healthcare. I'm not going to spend a lot of time going through the bill because I think you're going to do that. I have my section by section. I have all my notes. There's a lot embedded in the bill. There are a couple of things I think for me that are pretty exciting. As we talked with the expert from Yale, Zach Cooper, I don't know, did you hear from him? He's great. I think you'll like him. Well, he sets the economic playing field, what do you call it? Anyway, framework for understanding what we're doing. And you could go to our web page if you want to look at his slides. What really amazing to think he shared with us some unpublished data indicating analysis of what happens when you see a 1% increase in healthcare costs. So what happens? Well, there's a 1% decrease in jobs in the local economy. There's a reduction in tax revenue in the local economy. There's a reduction in income per capita in the local economy. And there's an increase in unemployment insurance payments. So that all goes together. And then you would think, well, is there corresponding employment increases in healthcare when you see that increased cost in healthcare? And the answer is no. Is there an increased benefit in terms of health outcomes when that increase in healthcare goes, 1% increase goes on? The answer is no. In fact, it's just, frankly, it's the opposite. And you can see a decline. And he has some pretty spectacular data that you can look at. One of the scariest ones for me that it increases suicide and mortality for males in the population that's affected. And he talks not just about the 1% increase, but also the 10%, as we're certainly seeing more than 1% across the board. But when you put all of that into the context, then we know we need to reduce, we need to change healthcare costs. We've all known that. But now we have the data to demonstrate the need to do it in a way that isn't sort of idiosyncratic, I'm paying too much and I can't afford and I can't get in and all the rest. We hear that all the time, and we've heard it since forever, but when we passed Act 27 3 or 4 sessions ago, and we heard that during our public hearings on healthcare. And I would like to remind you that we had public hearings on healthcare. People are calling for those again. I think the Oliver Wyman report, the public hearings that we've had in the past really fill the gap on what people need in our state, and we do listen. So establishing that economic baseline is very important, and it does help when you start looking at what's happened with the University of Vermont, the University of Vermont Health Network, which is also included in the bill, to understand where the administrative dollars are and where the clinical dollars are, asking for that. We're also in the bill looking to ask for common financial information to be reported to the Green Mountain Care Board so that there can be a common understanding and evaluation of that financial information when it gets to the board. And then, of course, we're looking at changing the way we pay for healthcare. We already have reference-based pricing within the Medicaid, within Medicaid. Medicare becomes Medicare becomes the basis for building reference-based pricing in hospitals. I won't go through reference-based pricing with you, but I think the one thing I will say is in putting reference-based pricing into the bill, we wanted to ensure a couple of things. One, that there couldn't be balanced billing within facilities. That's really important. Otherwise, you're going to end up with a reference base that's at 500% and another one over here, perhaps in an independent provider or in the same hospital, that's at 100% of Medicare. We can't have that. That disrupts the whole economy of the system. So my 2 cents. So building in reference-based pricing sort of across the system and aligning our system of care and reimbursement is important. Looking at commercial is very much embedded in the bill. It's about commercial insurance. And there is a section in there that Ledge Council can talk with you and do a better job than I can do on how what insurance is affected by that and can be affected by that. And then continuing to take our steps toward global budgeting, regardless of whether we have a head or not, moving toward global budgeting, which for hospitals, and beginning with one hospital to help to reduce the incline of price increases and to stabilize across the system. And then there's a lot in there, to say that, and there's a lot that's not in there. So one of the things that is in there is the sort of the learning plan. There's a plan in place that gets continuous improvement and addition to look at the gaps, to look at what's available geographically across the state, and then to identify how to continue to make the system fair and accessible. As part of that, one of the things that I personally wish we had had more time for would have been to include more about primary care in that plan itself and how to build a payment reform model for primary care. It can happen in there, and I hope you'll look at it. And I did spend some time talking with Chair Black and also with Elliot Fisher about that, and I gave my 2 cents, but you'll make it a dollar's worth. Yeah, no, I know that. So there's a lot in the bill. Trying to think, it's important to understand that the advisory committee that works on the plan is modeled after the Rural Health Care Task Force, and that came to us from the providers in the room, and it was extremely helpful to have that. When I put the members of the plan in, it was like, oh, I forgot to have the advisory committee. I better put people in there. So hearing who absolutely needs to be there from folks who have been involved in the Rural Healthcare Task Force was really helpful. And they've done that. And you can evaluate what you think works best there. There is fiscal note. It's not little, but it's not big. The Green Mountain Care Board already has 2 folks in the budget, and they've asked for 5 to complete all the work here. Those the two positions they've asked for, and you can hear from them on this, are related to the AHEAD process. But this really jives with AHEAD a great deal, so there might be some overlap there. We do need to have more people do this work. There's no question about it. We do need more resources at the Agency of Human Services. They are they're doing a good job right now with the transformation process, and we want that to continue. We're just at the edge of the cliff, and we don't want to go over it. So we need to keep doing this regardless of what the federal government is doing. There's just no question. And if we're going to have our hospital services and our local community healthcare programs, if we're going to have independent docs, if we're going to have other clinical docs, affiliated and unaffiliated, we really need to do this. So starting with the discussion in the press is all about, now finally it's about the crisis, right? We've been talking about the crisis for a long time. Finally, people are talking about a crisis. But what we're seeing in the press is all the bad stuff. What's the bad thing? What's happening? There were no solutions there. Okay, we want to know what the administrators are paying, executive branch is getting, executives are getting. We want to know what the salaries are, but that's just a little teeny weeny piece. And it bothers us. It bothers me that my hospital, that I think is great, is one of the highest costs is the highest cost in the country for certain services. But so the press has been just highlighting the problem. This is the beginning of a solution. And I think Oliver Wyman was part of that. I think Act 167 is part of that. I think we continue to plow along, get our work done in here. Whether anybody pays attention to what we do or not, I think it's the right thing. And so that I've said my piece on that, but I do think it's important that the work that we are doing together is so important. And I just have to say that the more I hear from people across the state, hear from individual hospitals, hear from individual FQHCs, hear from independent docs, hear from all the practitioners in our state, and how we're going to integrate services with our designated agencies and our specialized service agencies, our SSAs and our DAs, how we integrate with community services is really so important. And so continuing with the work of 167 and beginning to build this into that process, which it does, it's all there, I think is really critical for us all. I don't know what else to say, except you'll go through the bill, and if you have questions, I'm around. I'm usually here on Tuesday through Friday.
We have several questions. I have a couple also. I'm gonna start with Brian and then Mari and then Daisy. That's it.
Obviously, like what's happening on the federal level is hard to pinpoint because there's all these moving pieces. However, how much of this is reliant on the current system and how much would you say of the work that your committee did is we're going to be able to move forward with regardless of what happens federally? And if you can't estimate that, that's fine. I'm reading it in more detail right now myself. And we could ask other witnesses that question too, but you have a sense of like, 50% of this is viable regardless of what happens federally, or 90% is if we can find the money, or only 10% of this is going to be viable.
Well, I think you're going to have to answer that question for yourself, but I think about one thing I didn't mention that is very viable. For example, right now, there are contracts that are written between hospitals and insurers, or independent docs and insurers. We have no idea what's in those contracts. And they list the reimbursement rates. And so we have reimbursement rates here and here. If nothing else, we'll have transparency of that, and we'll be able to balance the money that we do have, whether we have it from the federal government or not. If Medicaid is cut by $200 million, then we'll have to deal with that. But there are policies in here that are going to set us on a more of an even playing field and open up some transparency. Well, I can't answer that. I can't answer your question, but I do know that it isn't lost on me.
Yeah. The other follow-up to it is, did the committee hear at all about what the impact of losing the federal subsidies or tax? I might be using the wrong language, so forgive me, policy people. The tax credits, the thing that I get, that makes my health insurance not be $800. It's 8 cents a month right now because of this benefit.
Losing the ACA
Thank you.
benefit.
Yes.
The subsidy. Yeah, so yeah,
APTC, that's what it is.
we could lose the money.
Yeah.
There's no question.
Has this plan considered that at all? Because if not, we could.
So when we passed this bill, we were nowhere near the federal crisis that we're in right now. Okay.
Yeah.
So no, but I will say that we are collectively, particularly in appropriations, talking about this. And I know that we will all be paying attention to it. I have talked with a number of folks about it. Yes.
Thanks.
We haven't started taking testimony about what the federal government is doing, because I'm not sure we know what the federal government is doing.
Yeah, and the latest budget reconciliation is not pretty.
Yeah.
Well, that's my questions. Thank you.
Mari?
Thank you, Claire, for coming to be with us today. I have, looking at some of the witness testimony, in particular from VPQHC, I'm wondering if the Senate did incorporate some of VPQHC's recommendations under section 6.
Pretty sure we did. Yeah. Yeah.
Including them
Right.
in consultation and the quality metrics that they would recommend.
Right. Yes, they are very important to quality metric analysis, and that's one of the things in the bills around the ACO. What the ACO has done for collecting patient data and doing quality metric analysis, it would be great to be able to capture some of that. In terms of VPQHC, they're there. I think you'll have to talk with Joint Fiscal and VPQHC about what their requirements are for money, resources. So, yes.
Thank you.
Daisy, thank you for this marvelous piece of work and all that you and your committee have done to bring us this. I'm curious how you discussed the reform of mental health services and payment and delivery. If this is about our whole, go ahead.
Yeah, so including an increase in mental health and substance use disorder. Yes, it's in there. We didn't spend a huge amount of time sorting it out. A lot of the work that AHS is now doing with transformation and integrating community services with hospital services to improve the continuum of care, it's in there. We didn't, Hub and Spoke is also in there. They'll have to find it for me as well, but yes, very much on our minds. And if you can do something to improve those sections of the bill, it would be terrific.
Any other questions before I have two. One is kind of a technical question about just one small section that I'm wondering where you were going with it and what your thoughts behind it were, because I was confused. And then one's a larger question. There's a section, the last, and we haven't done a walkthrough yet, but in section 3, it directs AHS in consultation with Green Mountain Care Board to implement reference-based pricing for services outside of a hospital, such as primary care. And I'm wondering, was this intended for Medicaid, or did you intend this?
Commercial insurance, everything here is commercial.
Okay,
So it would be payment for our DAs, SSAs, our mental health counselors, our substance use, all of that.
so even independent, even though no
Yes.
one has authority
Yes.
over, okay,
Yes.
okay, that
Trying
was,
to improve payment.
okay. I think my other question is, you have seen a lot of reform, and you worked a lot on various things. And as we're looking at this bill, I'm wondering if are there things that we have done previously that you don't think that have worked well, that you don't think that we should lose, that we can build upon in
Yes.
this bill?
Blueprint. Number one, blueprint, the blueprint for health. It's absolutely critical because of the way community health teams work together and integrate those community-based services. We really can't lose the blueprint. One of my concerns is, and I know Blue Cross and Blue Shield is sitting in the room, but Blue Cross and Blue Shield has a really wonderful program that actually mirrors, I believe, now I can ask them. I believe it mirrors Blueprint, but it would be nice to see all primary care integrated so that we don't have black boxes about patient data and about payment. So somehow opening this up and increasing the risk pool on one side and the access to services is really important.
Are there things that we have tried that you maybe think we should lose?
That we what?
That we maybe should lose? Payment models?
Well, yeah, I mean, the blueprint is a wonderful model for primary care. With all due respect, and I really value what's happening. I'm not sure it should be a program. And so if there's some way to spread it out across the state, and maintain the integrity of what is happening through Blueprint offices, yes, that's a whole big discussion, and it's one that I think we've had in the past. So I'll just go with that one right now. There probably are other things in the bill that, I think the conversation at the local level between hospitals. So I've heard from hospitals who are now talking together in new ways about how can they share and do things. That's so awesome. So what's happening with the transformation process, I think, is important to keep and hold and move it forward. It's a good question. I'll think about it more. What do we need to keep and what do we need to lose? We don't need to lose anything.
I meant models, payment reform.
You
Models.
got it. You got it.
Any other questions for their audience? Well, thank you. Thank you for coming in, and thank you for bringing
Can I
us.
say one other thing?
Yes.
Okay, reference-based pricing is only good if it has guardrails.
What do you mean by that?
What I mean by that is if you have reference-based pricing, that it's a percentage of Medicare, and you allow for one facility or service to receive a reimbursement at 500% of Medicare and another service that is comparable over here at 100% of Medicare, that's an imbalance, and this one isn't going to survive, and this one's going to become very costly over time. So trying to put the guardrails in place that offer fairness and balance across the geography and facilities. We do know, you do know, if you're going to have an academic medical center, it's going to cost more, period. You know that. And some bigger hospitals, you need more. I think Rutland is a really good example of having a terrific reference-based pricing system. I don't know how long so anyway, there's a lot of stuff in there, a lot.
Topper, you have questions?
I do have a question.
Oh,
In the bill, can you just talk a little bit about how you see what we have in front of us now? Of course, we'll build on that.
yeah.
How we keep people out of the emergency room.
Well, I think that's part of the bill. I think right now the costs are so high that, think long term. The costs are so high. People are not going to go to get the primary care that they need. And then they're going to get sicker and they're going to have an event and they'll go to the ED. We don't have an integration with our community services. We don't have the clinical mental health services. So instead of going to the clinic and accessing those services, they go to the ED. This is all part of it. And if we don't reinforce primary care as we would like, then primary care services are not available. So when you get something that might be a lower level need, healthcare need, you might go to the ED because that's what's available. So all of those things go together. And we know hospitals are concerned, and then we've done a lot in terms of increasing workforce, putting more resources into workforce, loan repayment, et cetera, doing that. Increasing opportunities for family medicine. It's all important.
So that would be where the healthcare delivery plan, once it's established, come in.
I think so. Yeah, I think you're right. How do you can make it better.
Yeah.
Did you have a follow-up to that?
No, I was reading the bill. I had a simple question.
Okay.
Uh-oh.
I'm only on page 24, so you're probably gonna escape before I get to the end. But why did the committee choose the Secretary of Human Services as the chair of the advisory?
Good question. That's an important question.
Yeah,
Having designated responsibility was something we heard about over and over and over again. And I think the board will reinforce that, yep, this is a good place for this to happen. It's not that they won't be working together, but that's where the kind of the lead, begin the process and work collaboratively with the board. But you do need to have a point person or a point organization.
I do see they have administrative and technical duties.
Yes.
So that was my assumption.
Yes, yeah, and I think they call the first meeting, I forget.
Yeah. But it says they should be the chair, and I wondered why would we get, because it depends on who's the governor then, who's going to be chairing and leading this, because they choose the Secretary of Human Services.
Well, let's hope that everyone gets on the same page in terms of lowering costs and increasing access.
In ways that help people, yeah.
Yeah.
All right. Thank you.
All right. Well, thank you. And tell the Chair of Appropriations that the dispensation was well worth it.
Okay, I hope so. But listen, after you go through the bill, I'm around. And if you want to have a chat, I'm glad to do that. Really, and thank you for taking the bill up.
Thank you.
Thank you so much.
Okay.
Okay. So I think first we're going to hear from Mike Fisher, our care advocate,
He said it, Sam.
and Sam. I'll do a walkthrough.
You know. So.
Good afternoon, Mike Fisher.
Sam Bush.
Thanks for having us come in. I think the job in front of us is to do a little bit of level setting. We're not talking about any individual sections of the bill. I think we're talking about the context that we're in and a little bit about how we got here and our perspective on the challenges in front of all of us. Go ahead. This is familiar language. Actually, let me do a couple disclaimers.
Oh, yes, of course.
Couple disclaimers. I think this works best if it's a conversation. And so we are, happy to have discussion in real time as we go through this. We've thrown together a bunch of slides that we think are important grounding in this conversation. You'll see that a lot of it is borrowed from others. Actually, all of it is borrowed from others, really, pretty much. But I did want to just pause for a second and recognize that it is so easy in health policy to forget about people. And, as we sort of stare directly at the challenges in front of us, I think it's just so super important for us. I know we all think about our own communities, but recognize, the real challenges that Vermonters face today and the prospects of those real challenges being significantly worse. What's it like if there's a loss of providers in my community? What's it like if I'm priced out of the ability to afford coverage? Those are real things that on some level happen today. And I think when we look honestly at the landscape in front of us, there's significant risk that those challenges can or will likely get significantly worse. You want to?
Yeah. So I think a lot of this is familiar to a number of you, but we're facing challenges really in every direction of our health, from every part of our healthcare system. You've heard about Blue Cross Blue Shield, their financial position. I think you've heard about FQHCs, independent providers, a number of them being on the verge of bankruptcy and closing. We also have a number of hospitals that just recently reported to the Green Mountain Care Board negative operating margins, so negative cash flows into the system. And a lot of them are really at risk of restructuring, being transformed, or closing. And there's real risk there. We also have a dynamic where if you look at the University of Vermont Health Network's obligated group audited financials, they reported $259 million of excess revenue over expenses last year.
And let me pause there. Early in the session, I articulated exactly that number and got some pushback. I know that the Health Network would much rather us focus on the operating margin, which is 80
You'd have to go back and
something $million. Given the crisis that's in front of us, thought it was really important to put their entire, not only their operating margin, but also the out of excess revenue profits that they also made on investments.
And getting back to, centering people, this is from 2021, the Household Health Insurance Survey, and we should have results of the newest iteration pretty soon, but at least 44% of commercially insured, privately insured Vermonters are underinsured. And I think there's a real risk to that number rising in the next couple of years.
So just we looked at sort of the history of healthcare reform and just starting with the 2011 or the passage of the Affordable Care Act. Vermont's been on a challenging ride, but with our attempt to pass boy, Sam, I should have seen this, a taxpayer financed, it never was single payer, taxpayer financed, a new way of paying for healthcare. That, of course, did not go exactly according to plan. And then also just recognize that, over the last number of years, we've put significant effort into the all-payer model. And that's been a lot of money. And it's also been a lot of focus. I think, we have put a lot of our hopes on what it took to reform the system in that approach. And while there might be a variety of opinions about whether there were aspects of it that were positive, I think that there's broad acceptance that it did not meet the goals. And so that's, I think, a part of the context of how we find ourselves here. And then you've heard me say this before. I'm the only one who I think is willing to declare that AHEAD is not going to happen. That is not official. Nobody has decided that. There are still people thinking about how to make it happen. I from where I sit, think that is highly unlikely. I think it would be good for us to have a clear recognition of that, if I'm correct. And hopefully that will come in the next days or weeks.
Is there a reason, Mike, that Catamount Health is not up there?
Yes, we started with the passage of the Affordable Care Act, and Catamount Health closed with our implementation of the Affordable Care Act because it was not allowable under it as we complied with the Affordable Care Act. But you're right. Catamount, if we went back a little further, we would recognize Blueprint, our passage of Blueprint, and our passage of the Catamount Health Plan, and BHAP, Vermont Health Access Plan, and Dr. Dinosaur. I mean, there's been a number of things that have been done in years past that were really good. Some of them continue today, some of them don't, but it's been a long, storied history on each of these things. Sure.
Yeah, so
We've planned this so well. We
Yes.
just-
Look at that first.
did you want to, sorry.
Oh.
Okay. So I want to talk a little bit about some of the common explanations, and by crisis, I mean, that initial slide. I think we've heard a demographic argument. We're too old as a state. Our utilization is too high. We're a rural state. Another one is we use community rating for health insurance, which is a bit different. I think New York is the only other state that does it that way rather than do rating based on age. We've also heard public payers are, quote, bad payers. There's an argument about our hospital service areas being too concentrated. And, as Mike mentioned, One Care Vermont, the all-payer model not living up to the expectations. So these are not all the things that we've heard, but these are, to us, some of the main arguments we've had, and we're going to kind of go through them and what the evidence is in our view.
You go.
Okay. As Mike alluded to, this is from the Green Mountain Care Board. And this was presented in 24. I really think I have Elena Barabee to thank for that, this slide. So just to kind of ground you a little bit, so this is premium growth, and you can see at the top you have, well, let me just start on the left. So we have Maine and New Hampshire are a bit older than us, or about the same age. And yet Vermont's premiums are at the top. And you can see where New Hampshire and Maine, they're in the middle towards the bottom.
Go back one.
Yeah.
Sam, I now can't remember. Does this include, is this silver?
Yes. Yeah. So this is the average lowest cost silver.
So disclaimer?
Yeah.
Vermont's rates are high. Vermont's insurance rates are high. There's no dispute, higher than anywhere else, we think. But there's a couple things going on in this slide that we should at least recognize. One of them is first silver loading, only silver loading on this slide. increases the cost of paper. And the other thing that makes Vermont different than every other state listed here, Sam mentioned it, Vermont and New York are the only two states that don't do age rating. And so the national standard is to look at a 40-year-old. And if you look at a 40-year-old in Vermont compared to a 40-year-old in every other state than Vermont, you get it's not apples to apples. And so that does, in effect, drive up the cost of health insurance for a 40-year-old, drives down the cost for a 55-year-old. But that's just another dynamic. I feel I'm sort of honest, wanting to be careful with the numbers, recognize that the Vermont line is somewhat higher than it would be if we really had a good picture on those two dynamics.
Yeah, so I mean, to kind of get at that too, so this is looking at lowest cost gold. And you can see, and this is of New England states, and includes New York. So Vermont, of these states, we're also, and you can see the change over time too, is something I want folks to look at. I mean, you can see Vermont went from 652 to 1139 in 5 years. And I mean, you see some increases in other states, but the rate of increase is not nearly, what Vermont's is. And yes,
Just look at the US.
exactly.
Yeah.
So I want to do a shout out to the two things that we just said, because we use gold here. The silver loading dynamic has an impact for 25, but in the opposite direction, actually makes gold look a little bit less expensive. But I think that I have always asked this question: what is the value of age rating? Because we don't do age rating, and I think you see it here. In that Vermont and New York look more expensive for a 40-year-old than the other states. So just want to recognize that. But Sam's point is that the trend is important to recognize. Our growth in expenses in costs to consumers is very high.
Alan?
So you're in this business, I'm not.
Yes, you are.
Yeah. Thank you. The difference is, for quite a few years, has been substantial. So as an expert.
We'll get into that. Yeah.
Okay.
That's where we're going.
Yeah.
Brian has a question.
And if you're going here, I'm not looking at your slideshow, so I'm sorry. I sometimes skip. I should do that. I usually skip ahead to make sure I don't ask, but I am going to ask this because I'm talking right now. How did New Hampshire do? They did. Because I see it go from 661 down. They're the only one who went down, I think, on that chart. How did they do that?
I don't know the answer to that.
We can put that on our list of things to explore, maybe. Hopefully it was a good thing and not like, they.
It wouldn't surprise me if New Hampshire was requiring less, that Vermont was requiring coverage for more care than New Hampshire, but I don't know the detail.
Like they might have less benefits in their insurance plans, so they're able to offer a lower rate, or they cut some things. Well, we'll find out.
So this slide doesn't have a link, does it?
Yeah, so this is from Kaiser. I can provide the link, but I'll update the slides and send it to you.
Kaiser's got there's another chart that we use Kaiser on, has got you can tinker with it. You can look at the states, you can look at the plans you want. It's very, very manipulable.
Yeah.
Manipulative.
Interactive.
Interactive.
You can nerd out, which I love doing. Okay, and also just about New Hampshire, I mean, remember, they're the same age, roughly, as Vermont.
You mean like the demographics?
Yes, demographics, yep.
Yeah, what is their secret?
Public
liquor stores.
Brian, this is Representative Chena, it is worth noting there's a lot of things going on here. It's too simplistic to just look at one thing. There's a lot of differences between states. So it's not just age and it's not just what's covered. It's also many other dynamics.
So this looks at the utilization question, is our utilization out of whack relative to other states? And again, this is from the board. No. I mean, goes up to 2022. We can get more updated data.
Because the colors are funky, point Vermont.
Yeah, so Vermont is the kind of salmon color, and it's towards the bottom.
So that's the answer to the utilization question. Or that's an insight to the utilization.
So we utilize more.
And it costs the lower one.
Yeah.
The lower
Vermont's
reddish.
on the, towards the bottom. It is.
Connecticut and Vermont look very similar color wise there, but it's the lower orangish red one.
Yep.
And hey, if you break out inpatient, if you just did inpatient, I think our number is even lower. And if you just did outpatient, the number would look higher. So we put it together here for simplicity, but.
Yeah.
It also means if you utilize less, you have to charge more to maintain the service. You know, there's that.
Yep.
Mari, sorry.
Is it those numbers or percentages?
So this is a median adjusted discharges. So it's like I think it's per 1,000 people. And just a word about utilization too, because I can't resist. I mean, utilization is also complex, right? There's some utilization that we want. And I mean, really, I think what we're all talking about is avoiding excess utilization and avoidable. Because we all know like delay and deferred care is, it's not as lower cost, it's not as effective. So I think sometimes not the conversations here, but they can get, collapsed and simplified in a certain way. So I wanted to call that out too.
Okay, some people say this was in response to public payers or bad payers. So amongst the New England states or
New England states, yep.
New England, Northeast states, because we got New York there.
Yeah.
Vermont's a particularly good Medicaid payer.
And we're around 14th nationally, if you're curious.
That's not to say that it's enough or that it could be high, that it covers the costs or whatnot, but that other states that are dealing with making it work, most other states have lower payments from Medicaid.
Yeah, to kind of build on the state of Vermont hospitals, I think it's worth to slow down a little bit on this slide. So negative numbers, bad. So this is for FY24 from the actuals reported to the Green Mountain Care Board. So we have 6 hospitals that are reporting negative operating income. And we have some hospitals that are doing comparatively better, and it's really Rutland and the University of Vermont Health Network hospital.
So when we get told that a hospital has a negative margin, an easy place that many people turn to is how do we get them more money? Right? Isn't that what people tend to think? Like, oh, well, they have a negative margin, let's get them more money.
Maybe, or how do we get them to balance their budget better or something?
Excellent.
Oh, okay.
So I want to recognize that any source of data is going to have some problems, and people often dispute data sources when they don't like the numbers. RAND is the best source of data that we have. Is it perfect? No. But I think it tells an important story. So IP is inpatient and OP is outpatient. And this, you get to see hospital by hospital, how they're doing. And I'm sorry, the numbers are what decile they're in. So just to pick the top line, Brattleboro inpatient is in the 3rd decile charges, right?
Mm-hmm.
And in the 8th decile nationally for outpatient. And so it is interesting to go back and forth between the last 2 slides and look at individual hospitals. Some hospitals maybe we're not allowing them to charge enough. And some hospitals are clearly charging a lot. charging are very expensive, compared to their peers nationally.
This price, is that like one inpatient day? What is that amount
Yeah, so-
correlate to, or just the average per inpatient stay?
Yeah, I can send you more information on that. So the standardization process includes, things like like GME, like graduate medical education payments, so like these other pieces that Medicare factors in, like case mix, like, for example, UVM is the only hospital that takes care of like our most complex patients, right? So there's different adjustment factors. And Chris Whaley at Rand, who worked on this, I might just say like he's a great person to talk to about this. Really thoughtful. He's at Brown now. But he can walk through the details on that. And the standardization really kind of attempts to level the playing field. So we're doing as close to apples as possible. And one thing I'll say too is, UVM is a much larger hospital than say a Scutney, or a Copley. So, a price being high at Copley has a differential impact on our system than a UVM or a Rutland or bigger hospital.
I think I'm just trying to understand, it's like the cost to provide care in each of these, or is it their actual price in a dollar figure? No, it's the cost. This is how much it costs them to provide that care.
So that's a great question. So this is built on real commercial claims.
Okay.
So this is paid amounts.
Okay.
Go ahead.
Yeah, so this looks at OpEx's operational expense growth per just discharge. So this is again looking at a lot of New England states, and we're near the top.
Again, the colors.
Yeah, so
We have a member of our team who really cares what colors to use on slides, and we borrowed these slides from other sources. So if he's watching, he's screaming. Yeah,
rightly so. Yeah.
rightly so, because they're hard to tell.
And they change.
Yeah.
Like Vermont was salmon.
Mhm.
Yeah.
It was vermilion.
What's the red top one? Is that New Hampshire, Maine, or Massachusetts?
Maine.
Yeah. Okay, that's Maine. Okay.
Yeah, it is hard to tell.
Is it purple? Is it
Yeah.
It's like a cherry red.
Salmon is my favorite color. I would have stuck with.
purple key? It's beautiful for the person that made it, and we thank them very much.
I think it's good. It's just hard to see on this
So
monitor.
the bottom line is there's a little dispute. Vermont's expensive.
Our operational expense growth is pretty significant. It's higher than other states.
Yeah.
Most of the states.
Wait, I'm sorry. So operational expense, that is administration, non-clinical care or non-clinical.
I would say like,
Costs.
yeah, to maintain operations.
Okay.
Yeah.
I don't know, these are so self-explanatory. This is a pivotal moment. We don't think, we were playing around a little bit with this word courage. I actually don't think courage is right. I think we are forced at this moment to make some real changes. I'm not sure it's courage when, what did the previous witness, what Senator Lyon said, we are up against a cliff. We don't want to go over it.
It's more like the serenity to accept. I think of that prayer, like the serenity, or is it right? Is that what you say? The courage to change the things I can.
Wisdom.
The serenity to accept the things that I cannot, right? And then the wisdom to know the difference between the two, that it's serenity to accept that these things have not worked. That's how I feel about it, at least. And then the courage is what can we change?
So then the last slide, isn't it?
Yeah.
So this is just to drive home and put it in the terms of the calendar, this year's calendar in front of us. This is not theoretical. This is playing out right before our eyes. I am sure that Blue Cross and MVP is hard at work developing their rates and being ready to submit them. May 12th, I think, is the number. That's right around the corner. And I expect that we will look at those rate proposals and go, wow, how are we possibly going to, how are small businesses, how are Vermont families if we lose the enhanced premium tax credit, going to manage those costs. There's an interesting dynamic that plays out every year just before the insurance rate cases hearings happen. The hospital budgets are proposed, and we all of us in the middle of the rate cases go, wow, this upsets the apple cart, tends to every year upset the apple cart on the rate cases we're in the middle of. And so I got to hand it to the Green Mountain Care Board. They are in an impossible, and therefore all of us are in an impossible set of decisions in front of us. They will have this annual weighing of solvency for an insurer versus affordability is going to be an impossible thing to weigh this year, as at least one insurer, as the insurers need contributions to reserves in order to remain able to pay their claims. In order to pay their claims, is going to, in our opinion, push many more people out of the ability to afford the care, afford coverage. And any prospect, I mean, if we were to at this table say, hey, let's figure out how to make sure the carriers don't need to increase the rate so much. Like, what would we need to do in order to make sure that more people, so many more people aren't priced out of the ability to get care? On the back of the napkin, I think we'd need to pull $200 or $400 million out of expenses in our healthcare system with corresponding rates, with a reduction in corresponding rates. And that would be quite an exercise. That would be quite a challenge to figure out how to do. And there's people thinking about this, but that's the kind of challenge that's in front of us. Talking fully transparently here and recognizing the
Brian,
significant challenges in front of us.
thinking I question myself.
I didn't want to
Brian.
distract you.
No,
You
I'm
saw me
just
though, okay.
turning something in my head.
I'll fill in the space and see.
No, go ahead.
So I'm listening to you and reading this and processing it all at the same time. And there's a piece I feel like the bill doesn't really address, and you haven't brought up, that I want to throw out there to just get out there for people to start considering, which is this evidence-based practice of motivational incentives or contingency management. It's being used right now in Vermont with opioid settlement funds to treat substance use disorder. But essentially what it is rewarding people for healthy behaviors. And I'm just wondering, like, if there's room in this discussion as we talk about cutting costs, that what if it wasn't just about like creating a barrier for people going to the doctor, like making them pay a little so that they don't just go excessively. But what if there was some way to reward people that they were really physical? And I'm not saying punishing people. It's just that, like, it could be that a person has a major chronic health issue. And for them, the goal is like, how do I keep my weight stable? Or how do I keep my cholesterol stable? Or how do I, some realistic goal that they could, or like if they have diabetes, how do I keep my blood sugar stable? And maybe for someone who's in a healthier condition, it's a different goal. Like, and the providers could set these things, but has anyone ever looked at using motivational incentives as part of healthcare delivery to encourage healthy behaviors? Because I think I said this earlier, I don't know if we were on the record yet when I said it, that I think that the last I looked, and someone might have a more recent study, that 34% of the social drivers of health is healthy behavior, and 16% or something like that is access to healthcare. And that's why health outcomes are shaped 50-something% by health, but it's not actually access to healthcare. It's the healthy behaviors that have more of an impact. And so if we considered that, then that would actually improve health outcomes dramatically, and then in turn save costs in the long term. Has anyone even looked at motivational incentives at that scale? Because I know we're looking at it on the micro level in terms of treating substance use disorder, and it works. Like, it actually makes sense to pay people to be clean. I know that is ridiculous as that might sound, but some people it works. They end up I can't give you the numbers right now, but we can bring an expert in for this.
So, Brian, you're absolutely right. It's healthcare 101 to recognize what story health has less to do with what happens in the clinical setting, what happens in our lives. I think the challenge for me at this moment is to steer us back. I think there's some very short-term crisis things we have to attend to. And there's many, many moderate and long-term things that make perfect sense. I think at least for me at this moment, I'm looking at this, I'm wondering, how do we get through this year? With all due respect to your idea, which is very good, I think that kind of an idea doesn't address the challenges in front of us that are this year, that are not about changing people's behaviors, but about figuring out how we're going to pay for the care that people need today.
I see you, Mari. I'm gonna ask a really cynical thought that I'm having. So I'm just thinking about this year's rate reviews, this year's hospital budgets. I'm thinking about the end of the enhanced premium tax credits. I maybe just anecdotally, I know a lot of people who will choose to go without coverage next year.
Yeah.
A lot of people who in their wildest dreams never would think of being uninsured are going to have to make the decision to go without coverage. And I'm wondering is if we lose a significant portion of people from the market, if we lose a significant portion of employers, small employers who offer health insurance to their employees, because I think that also might be coming. Would that be helpful to Blue Cross Blue Shield, or would it be detrimental to their solvency issues? Would we be losing healthier people
Well, so
and be left the insured from an unhealthier population, or would we also be making market corrections for hospital sustainability, insurance solvency? Would a huge decrease in the number of insured in our state lead to a market correction that we haven't had the courage, and I'll use the word courage, the courage to take actions to fix?
So this is maybe it is adverse selection, or maybe it's the opposite of adverse selection. If you put two individuals in front of you who have identical income, both of them are really challenged to afford care, and you make one of them with a chronic condition that needs ongoing care, and you make one of them really healthy, they make different choices. It's the people don't leave insurance markets on average. People leave insurance markets who think they're not going to have expenses. And so it's a little bit of the opposite, I'm afraid, Madam Chair, that it's as sort of the concept of a death spiral is that as costs go up, more and more healthy people leave, leaving only sicker and sicker people in a market.
Yeah, I mean, just on the hospital piece too, if folks are leaving insurance and going without it, hospitals are going to be getting less revenue.
And those people who took some of those people who took that risk and said, I'm going with insurance, will do just fine and get through the year without any problem. And some of them will get a bad diagnosis or an accident and will be getting a whole lot of care. And there's just substantial risk.
And that's dead, right?
Yeah, that they won't be able to pay for that care.
Mari,
Just to, in response to Regina's question about motivating factors for health improvement, I think is heading down a really fraught road, because a significant percentage of people with health issues like, obesity, high cholesterol, people who might gain weight because of heart failure, because of a genetic disposition towards cardiomyopathy. There's so many other factors that individuals don't have control over. Genetics is a big part of obesity. Genetics can be a big part of high
And
cholesterol.
if I could add environment,
Social determinants of health, the environment, race, are all things that people don't have control over. So I think it would be really problematic to go down that road on an individual basis.
so I hope this has been uplifting. We said to ourselves that we wanted to keep coming back to individuals and people in our communities, and it's hard to sort of know how to do that at this moment, but this is a tough moment, and we in health policy circles spend a lot of time staring at it, thinking like, how do we get out of it? How do we manage it? How do we get through it in the best shape we can? And you know, let me just try. Of course, we're going to come together as best we can and we're going to do our best to make the best decisions we can. Going through this calendar, and the board will, and we will advise, and Vermonters will comment. But I really appreciate the bill that's in front of you. It addresses a number of things. I think there's some things that could be built stronger. And there's probably areas that it doesn't touch that it wouldn't be bad to address. And then finally, I know we've mentioned the sunsetting of the enhanced premium tax credits a few times here. There's a raft of other things that could or will likely come at us from DC. And to Brian's earlier question, this is all before that.
Oh, Leslie?
Yeah, Sam's got a helpful.
Well, yes, if I may.
Okay.
I'm feeling a little stuck, because the short term seems so dire, and this bill seems like the implementation is going to be fairly long term.
Mhm.
How do we get from here to here without losing more of our system?
I think that's what we're gonna work on for the next couple of weeks.
Yes.
But this is still
Yeah.
wrong. I mean, how do we figure out how to move this more expeditious, or maybe it can't be, I don't know. But I'm feeling worried of how to get through this year, losing, having more hospitals are red, losing more hospitals, et cetera, before we can get to a fix. Yeah, because I know this is gonna be adopted on passage, but then by the time
That's why we get to spend a lot of time with it, and we can make improvements or amend things as we see fit.
This is the last major bill we have, right?
This is the last major bill. It is my intention,
So-
except for there's one other S63, which has to do with modifying the regulatory duties of the Green Mountain Care Board, which I think we will probably be working in, forget about it. That I think we'll be working in conjunction, but these are our last. I anticipate we're gonna spend the rest of the session on all these questions. And I know that we will be hearing from our healthcare advocate many times. Thank you. I wanted someone to come in before we did a walk through the bill to sort of set the stage of where we are now and why this is in front of us, and let us come up with ideas, Leslie, on how we want to work and maybe use this as a framework. Okay.
So I have a positive thing to say. Let's see.
Yeah.
See whether.
Yeah, Phil stopped to end on a somber note, but just the one thing I'll note, I've been at the HCA for 4 years. It does feel like the conversation and the willingness to look at what has worked and what hasn't worked is different. And that's just my perspective, but it feels different. Like it feels like we're willing to look at, maybe I shouldn't say mistakes, but things that haven't as worked as we expected them to. And this stuff is complicated. it's not reasonable to expect that, you know, we're going to get it right every time. But I do think we need to admit where things didn't live up to expectations. So I think that's a good thing. I think we need that. So.
Thank you. Yes, thank you.
Almost positive, yeah.
I think we're gonna take a short break.
Thank you.
Yeah,
I can't breathe.
it's hot in here, so let's take a short break. Be back at 2:30. Okay.
Is it,